Let's talk about the nitty gritty, okay? Let's talk about daily life. What are we doing on a daily basis? Now, I haven't progressed past second year house officer, so Sanjeev, you're gonna have to retake over a lot when it comes to some of the stuff later on. That's gonna be your spotlight. On the daily basis, being a doctor is okay. Number one, let's just be very, very clear here. Now, my objective here for you guys listening is not to over glorify the medical career. I want to provide a balanced opinion. I want to tell you what it's really like. You know, I want you to know what you're really getting yourself into. There are a lot of things that make it really worth it. There are a lot of things that would be complete deal breakers if you knew about it and if that wasn't aligned with your personality or what you wanted. And so I think it's really important to the best of your ability, have real reliable information about the career that you're working in. And even if you later decide to change paths, that's okay. But I think it's just important to lay that information out there. So, I mean, anything that I say, if it's new information to you, if you've never heard of it like this before, leave a comment about anything that you want us to go into deeper. Just a little plug. We also talk about this type of stuff a lot on our podcast, which is Subcut. So you can check that out. jttmed.com/subcut. Anyway, so working as a junior doctor, the juniorest of doctors, a house officer, your day on the ward can be incredibly tiring, stressful, but also tedious and boring, and in a lot of ways quite monotonous. And it is simply the nature of the job. So the way that the hierarchy of a medical team works is that there's a senior doctor who is the one that's like the brain. They're the ones that are making the plan and the decisions. Mm-hmm. And the registrars and especially the trainees underneath them are like growing the brain. They're trying to learn as much as possible. They're trying to experience as much as possible. They're facilitating that, and they're making some of the smaller level decisions that the consultant at the top might not really bother trying to sort of flesh out in that much detail. So a lot of that daily decision making is going to be made by the consultant, and a lot of the within the day decision making, how that plan gets executed, will be made by the registrar. And so the only decisions that the house officer ends up really making are the very, very fine ones that I think revolve mostly around how do we make sure that the patient is able to just get that plan done? How do they make sure that they're going to end up getting the surgery? How do we make sure that they're not going to just randomly have some deteriorating event on the ward? We're just kind of maintaining and optimizing and just keeping things going. And if there's a plan, we're the ones that are going to be the ones calling up to make sure that it gets done. We're the ones that are filling in the forms and booking things through so that it gets sent. We're the ones that are charting medications or recharting medications, because we freaking use paper medication charts written by hand. We're one of the only developed countries in the world that still does this.
Except for North Shore Hospital now.
Except for North Shore Hospital, which is North Shore Hospital is like in Auckland, is the it's like the future of healthcare in New Zealand, to put it bluntly. So there is a lot of that sort of tedious stuff. So the work is meaningful in that it is purposeful, as in if you weren't doing it, there are going to be some serious issues with the entire healthcare system. So that's not arguable. But the nature of the work doesn't always feel purposeful because it doesn't seem incredibly cognitively complex or super difficult to do. Although if you were to get a lay person to do it, it would just be completely impossible in a lot of cases. So for example, even just making a simple phone call to a colleague, that is an incredibly technical skill. I mean, I don't know, Liz, about you, because you had a lot more experience going into it, but
no, still crap my pants every time I had to ring a boss. Yep.
Yeah.
Or even a senior reg.
Or even I remember my first phone call, and I was so nervous. I had to prepare for like 10 minutes, like
write it down.
Yeah, I had to write everything down. Yeah. And eventually that sort of stuff, which you got to remember, like, I mean, by the time you've graduated medical school, like you do have a level of like competency, to be honest. So for that person to be needing to spend 10 minutes to practice a phone call, it means that there is actually quite a lot of technicality to that communication skill, being concise and efficient and doing all of that.
And asking the question.
Yeah.
What is your question?
Yeah, being direct and that sort of stuff. And also it means that in our day-to-day normal lives, it can be quite frustrating when people are ineffective communicators because they just don't get to the point quickly enough. So that's kind of from the house officer's point of view. That's what the daily life kind of looks like. It's about facilitation. It's about making things happen. It's very execution oriented.
The only thing I'd add for that is that you do a lot of on-call. So we keep the hospital going at nighttime on the weekends.
Yeah.
And we pull some massive hours. Like, I had no idea. Even I was a nurse before I went to medical school, and I had no idea that doctors would start at 7 a.m. in the morning, rounding on surgery, for instance, and then you're on a long day. You're admitting patients till like 10, 11 o'clock at night. You get home at midnight, and then you're back for a post-acute the next day at 6 a.m. to prepare all the patients that you admitted. And I just... yeah, that's one thing that's still the long hours.
There are long hours, and they're meant to be sort of rostered in. But look, you're always working overtime. There's pretty much no instance where you're not working more than your rostered hours, unless you're lucky. So if you start at 7, you are there at 6:30 or 6. If you end at 10, you're leaving at 10:30 or 11. Or if you're Sanjeev, who was working for a long time as an orthopedic registrar, because I was actually Sanjeev's house officer. You know, Sanjeev would do a night shift, and you like leave after lunch. Like you were at you pretty much freaking lived at the hospital. I think you can tell us a bit about long hours.
Yeah. And I mean, I think that's probably something that we don't realize when you get into the job is that just the pure time commitment. It does, especially that first year. You've been studying for a long time. You've had the fun of being a student, and then that first year you realize, man, working's pretty hard, and the hours are long. And I'd like to say the hours get less, but as you train, because you're accumulating more experience, more responsibilities, the hours probably get a bit more. I think the work gets a bit easier, but the hours probably keep going. And probably something that would have been nice to know is that the time commitment is a thing quite big, and you're essentially learning for life. Like you could be a doctor who's been a doctor for 40 years and you will still get stumped by patients and their problems. So you're always learning. I guess I could give an example of what my day looks like. So like once you've done your house surgeon time, you become a registrar. I did orthopedics for quite a long time, which is orthopedic surgery, which is dealing with broken bones, fixing joints, things like that. And so our day usually would start at about, you get to the hospital by about 6:30 or 7 if you're lucky, because you can have a sleep in. And then you'd usually go and see all the patients that are on your team that belong to the consultants that you work for. So you'd work for maybe 3 or 4 different consultants. And so me and Justin would go around and see all of them and make sure there've been no problems overnight, no issues. And then in the morning, there's always a handover to see who the new patients that came in are, which ones need operations, which one needs different plans. You'd go through that, and then depending on what you're rostered on for that day, you'd go and start your day. So you'd do your ward round, you'd make sure everything on the ward is sort of under control, and then the house surgeons would essentially look after the wards after that. So they're busy making sure patients are being sorted on the ward, and then the registrar would either go to theatre, so go in operating theatre and go learn how to do surgery, or they might go to clinic to follow up on patients after surgery, or they might be in the emergency department taking phone calls and referrals and seeing patients that are coming in. So people with broken bones or infections or problems that the GP's found, and you do that, until the end of the day. And end of the day was always a variable endpoint. Could be you could finish at 5 or 6, or if you're doing like an on-call or a long shift, it's technically meant to finish at 10, but you might leave at midnight. So the hour's definitely long. But I mean, during that time, you're doing a lot of learning, a lot of cool stuff as well, which I'm sure we're going to talk about soon.